Last lesson we looked at old public health, which was really about decreasing the rates of infectious diseases, respiratory diseases, injuries, the types of things that used to cause a lot of death in the early 20th century. And they really focused on improving the physical environment and nutrition and things like that. Today we're going to look at two kind of different approaches to health, and it might, as we go through it, at times it might seem a little bit confusing or conflicting, but hopefully by the end it all ties together nicely and you can see the relationships between the public health we've already talked about, this biomedical approach, which we're going to talk about today, and then also new public health, which again we will talk about today. I think the best way to do this in your notes is actually to make a small summary diagram, and then we'll go into each of these in a bit more detail. But it's good just to have the key points written down. So we often talk about two different approaches to healthcare. And the first approach is the biomedical model. So you probably think these terms sound quite scientific, and that is kind of what this model is. The biomedical model of health, or approach to health, focuses on the biological aspects of disease. So it's really focused around things like diagnosing and treating diseases. Because of that, it kind of focuses on individuals as opposed to the community. So if we think about getting diagnosis and treatment for something, you only get those things if you're unwell or if you kind of have a disease or a disability, okay? It's not something that's done to everyone. It's kind of done once people are already unwell. And because of that, what it's really doing is it's treating the condition and not the cause. And we'll look at some more examples with this, and especially when we compare the two models, that should be a bit clearer. Okay, so they're the key points about the biomedical model. The social model, which is also what we call our new public health. So we talked about old public health. New public health is kind of in this social model of health. The social model of health focuses on behaviours and also factors that influence our health. Now, we looked at different factors, sociocultural factors, things like socioeconomic status, education, all of those things can affect health. So these things are considered in the social model of health. It focuses on the community, not on individuals. Okay, so this is a real, remember we're talking about public health here, so it's really about things that target either the whole country or big populations, big groups of people. And compared to the biomedical model, it addresses the cause of diseases and health problems, but not the actual condition itself. Okay. Again, we'll look at some more examples as we go through. We're going to start with looking at the biomedical model. It's important to note, and we'll come back to this at the end, but a good health system has both of these things going on, the biomedical and the social. So it's not really a debate about one or the other. They both kind of need to work together to have a good, effective health system that looks after the health of a country. So the biomedical model, got a few pictures here that probably give you an indication that we're looking really at kind of scientific medical treatments and technologies. As I mentioned before, it's aimed at diagnosing and treating diseases, illnesses, or disabilities once they have started. Because of that, it relies on medical technologies, things like medicines, being able to have surgeries, and also things like medical devices. So if someone, say, had a car accident and became paralyzed and they needed a wheelchair, that's considered to be a biomedical invention that helps them to get around. Okay, not everyone needs a wheelchair. It's specific to people that have a certain disability or illness. Okay, and there's lots of different examples of things that we could include in that. You could include glasses, for example. Not everyone needs glasses. It's only people that have vision problems. In general, biomedical approach interventions are provided by doctors, nurses, in things like hospitals and clinics. So usually the places that you kind of think about or you associate with health come from that biomedical approach. And this approach was really the main approach for a lot of the 19th century. So up until about kind of the 1970s, this really was the main approach to health. And obviously it still continues. If someone is sick now, they will still go to the doctor and they will get medicine or they may have surgery. So this approach still exists. But as we'll look at a bit later, the other approach kind of came in towards the 1970s. Once you've written down your notes on this, just pause this and head into the Google Doc and answer question 1. All right, you know how much I love my timelines. I figured this time I'll give you the timeline rather than you having to make it. You don't need to write this down. You don't need to memorize certain things that happened. I just think it's always good to give some examples of what we're talking about. And if you find that interesting, you're more than welcome to take this from the slides. But don't stress that you need to remember when all of these things happened. Okay, so we look at some of the key biomedical advances in the 20th century. And these are just a very limited number of examples. So around 1914, the first ECG was developed, or what is better known as a heart monitor. So that was kind of the first time that doctors could kind of listen to someone's heartbeat and get an idea about their health through that. Aspirin was developed around World War I time. So aspirin, which is usually used as a pain relief medication or to thin the blood. So a very kind of widespread medication. In 1922, insulin was first used to treat diabetes. And obviously that is very widely used now by people that have glucose regulation problems. Penicillin was discovered in 1928. I always think that's just a good bit of general knowledge to have. It was such an important discovery, but that basically introduced antibiotics, and that was a huge, huge, huge development in terms of decreasing infectious diseases. The first blood banks were used in the early 1940s, and if you're a bit of a history buff, you've probably realised that was during World War II. So the need for being able to provide blood transfusions to people that were injured became a real need then. So the first blood banks where people could donate blood and they could store it and provide it to people that needed it. Kidney transplants began in the 1950s. And the technology would have changed a lot since then, but that was the first one that was done. Asthma inhalers. If any of you are asthmatic, you're probably quite familiar with these. But sometimes it's interesting to look at these things because you might think that, an asthma inhaler is much more simple than transplanting someone's kidney. But just certain parts of the technology for an inhaler didn't really exist until then. The first heart transplant was done in the late 1960s. MRI machines, so they're magnetic resonance imaging. Some of you might have had it, but they're a type of imaging that's done to look at injuries to ligaments and joints. And the first laser eye surgery was done towards the 1980s. Okay, now just have a quick look at those things, and you'll probably notice that with pretty much all of those things, they're used or they're done on people that are complaining of illness or have an illness or have a disease. Okay, these aren't things that we just go and do for everyone all the time. They're an individual thing when people need them. It's important to look at some of the advantages and disadvantages of the biomedical approach. And this is in the study design that you need to know these. So some of the advantages of this approach to health. Firstly, it lets us to develop new technologies and research. And that's hugely important. Without people inventing these things, we don't get improvements in health. Okay, so the conditions that can be treated or can be cured now that couldn't in the past can only come from this approach to health. It allows us to treat diseases, and that is hugely important. I'm sure anyone who's been sick themselves or has had a chronic health problem or has family that have had those things understand how important it is that if someone is unwell, that they can be treated. Biomedical technologies have had a huge huge impact on increasing life expectancy. We've looked at lots of graphs of how life expectancy has changed over the last 100 years, and so many of those decreases in death rates were due to things like antibiotics or bringing in vaccines. So things that can cure disease obviously will mean that people live longer. And they also improve the quality of life. So let's go back, for example, to a person that's had a car accident and is paralyzed. If things didn't exist that would help them get around, the quality of their life would be really low. So all of these kind of things, I mean, if you're someone with a lot of pain and you can take medication that reduces your pain, that's going to improve your life. If you have problems walking and you can use a walking stick or a wheelchair and you can get around on your own, that will improve your life. If you have eye problems and you have glasses and you can see clearly, that will improve your life. Okay, all of these things improve people's quality of life when they have a disease or an illness. There are also some disadvantages. So the first disadvantage is that the biomedical approach is quite expensive. Because it's really focused on individuals, the cost can be quite high, and it relies on medical professionals and I guess also medical facilities. Okay, so the cost of providing care to someone in a hospital, the cost for the doctor's fees, the medicine, surgeries, that's really expensive. The biomedical approach doesn't address the cause of diseases or illness. So let's use the example of lung cancer. So if someone was diagnosed with lung cancer and then they had treatment and medications, they might have some surgery to remove a tumor, that would be the biomedical approach. So that's going to help treat their disease. It might make them live a bit longer. It's going to improve their quality of life. It doesn't address the reason for that lung cancer in the first place. So lung cancer is usually caused by smoking. So it doesn't do anything to necessarily change whether or not that person smokes, and it doesn't help other people that maybe smoke and are at risk of getting lung cancer. And another limitation is, not everything can be treated. We have an excellent healthcare system now where most things can be treated, but obviously not everything can be. And I guess there's a bit of a cycle between these two here, because things that can be treated now couldn't be treated 50 years ago. So in time, I'm sure we'll see huge advancements in what can and can't be treated. So once you've got these jotted down, just head into the doc and answer question 2. Right, we're going to spend the majority of this lesson on the social model. Okay, so this is the other model that we kind of work with alongside the biomedical model. The social model, as I mentioned before, is also known as new public health. Now, in the exams and in SACs, those terms are often used interchangeably, so it's worth having that written down. This model of health really started in the 1970s in Australia, and that was because of the changing causes of morbidity and mortality, which we've discussed before, but they're things like our lifestyle related diseases. Okay, so they became a lot more obvious in the 1950s and 1960s. And by the 1970s, the government and the health department said, look, we've got to focus on these things. Another thing that became really evident at that time was these inequalities in health status. And a lot of these we looked at in Area of Study 1, but inequalities, for example, between people with high socioeconomic status and people with low socioeconomic status, or between people from different racial and ethnic groups, Indigenous versus non-Indigenous Australians, males versus females. These inequalities became obvious, and it became clear that you can't just have a one-size-fits-all approach to health. You've got to focus on certain groups or certain people a bit more. The social model of health considers the role of physical, sociocultural, and political factors. That's interesting. It takes into account socioeconomic status, access to healthcare, and social connectedness. And we'll look at those in a little bit more detail. And it's got a real focus on community development. Okay, so where we said the biomedical approach looks at individuals, the social model of health focuses on the community or an entire city or an entire country. Okay, so get those notes written down, then head into question 3 and just see if you can kind of summarize, make 1 or 2 sentences about what the social model of health is. All right, there's a bit more detail that you need to know on the social model of health than the biomedical model. And this stuff will kind of keep coming back over the term when we look at different examples in different health programs. So the social model of health is considered to have 5 key principles. It's up to you how you write this in your notes. If you just want to list them one under the other, you can. If you want to make a bit of a flow diagram like this, you can. In this, I'm just going to go through what the details of each of these are. And then on the next slide, we'll look at an example, which hopefully will make it a bit clearer. So the first principle is that, well, they're not in any order, but one of the principles is that the social model of health acts to enable access to healthcare. And we've looked at some of the barriers to accessing healthcare before, but to have a good social model of health, people need to be able to access healthcare. So you need to consider things like language or culture, economic factors, so whether or not people can afford to access healthcare, where people live, and also their education levels. So can they read health information? Can they access that knowledge? The social model also focuses on empowering people. So giving people knowledge and skills to make healthy behaviours. Okay, so if the aim of this is to change people's behaviours, they need to know why. We can't just tell people to do things or not to do things. It's really important that people have that knowledge and they get to make their own decisions about their health. Social model of health addresses the broader determinants of health. Now, I know that term seems like a bit of a mouthful, but if you think about it, a determinant is basically something that determines something, or I guess you could say that contributes to something. And all of these we have looked at. We know that people's gender can influence or contribute to their health. Their culture can contribute to their health, their socioeconomic status, where they live, the physical environment that they're in. They can all impact their health. So the social model of health just acknowledges that and tries to address those things where possible. Again, another big term here, but if we break it down, intersectoral collaboration. So we know that to collaborate with something is to work with someone or to work within a group. Inter is just between, and sectoral is sectors. So this is basically saying that different groups will work together for the common goal of improving health. So usually our health department is in charge of people's health and health programs, but in the social model of health, those departments will work with other departments. So maybe things like the education department or employment, or let's say the road safety department, because if we're trying to decrease the number of car accidents, which is, a health problem or a health risk, we might need better quality roads, we might need road laws. And also working with the private sector as well. So sometimes a health department might team up with private companies or businesses to roll out a certain program. And the fifth principle is that it acts to reduce social inequalities. Remember we said part of the reason for this model was that inequalities in health became really apparent. And so if we know, for example, that having a high SES means someone tends to have better health and a low SES means poorer health, well, what we need to do is try and close that gap. How do we help the lower SES maybe increase their situation? Okay, so even though it's not technically to do with health, programs might try to improve education or to look at increasing employment opportunities, or maybe providing or helping people access better housing, all those things which we know can contribute to health. Okay, so you do need to have some details written down on the 5 of these. If you would like, in the next slide when we look at the examples, you could maybe put some examples in to help you. Before we move on, just pause this and jump into question 4 and just write down what these 5 key principles are. All right, so let's look at, say, the social model of health in Indigenous healthcare. And this is going to be a really simple example. There's not a lot of detail here, but I just want to give you a bit of an example of what each of these might look like. Now we're going to start actually down the bottom right here. Like I said, it's not in any particular order, but part of the social model is that it addresses different factors or different areas of health. So the fact that the government has specific programs for Indigenous people is an example of addressing these broader determinants. Okay, they have acknowledged that people with Indigenous people have different health issues sometimes to non-Indigenous people. Okay, so the fact that they have different programs is an example of this. And then within that, they might even say, okay, Indigenous males and Indigenous females have different health needs. So we're also going to provide different programs based on males and females. Intersectoral collaboration. Okay, so when rolling out a health program, the health department might say we're going to collaborate with Indigenous organisations. Okay, so it could be local community organisations that are relevant in that area. They might collaborate with the Indigenous Affairs Ministry, so at the government level. Okay, so starting to work with different groups that aren't just in health. As part of a big health program, and this could link quite well with working with these other sectors. But part of the aim might be to improve education and employment opportunities for Indigenous people, knowing that those things often mean improvements in health. There might be programs to try and improve housing, to make sure that there's good sanitation, good clean water, people have access to good cooking facilities, things like that that are important for health. When enabling access to healthcare, the government or whoever's running this program might say, okay, we're going to use Indigenous health clinics and Indigenous workers for this program because that's culturally appropriate. This term will come up a fair bit when we look at things that are culturally sensitive or culturally appropriate, acknowledging that people from different cultures may have different needs in terms of their communication or in terms of practices in terms of how they work with other people. And finally, empowering individuals and communities. And this really is the main aim. How do we give people the knowledge and skills to make good health choices? So there could be things, programs that educate about health issues, and that could be done in lots of ways. There could be messages on radio or TV. There could be pamphlets that are sent out. You can have apps. You could have workshops where people learn different things. And often it's not just a matter of educating, but you might need to actually provide some skills. So if a focus of a program was to decrease obesity, just educating about obesity might not be enough. You might need to, say, run cooking classes that help people to cook healthy foods, run exercise groups so people have that support and motivation to exercise. Right, I want you to have a look at each of these examples, and in the doc in question 5, I want you to pick the principle, which are these 5 things over here, that relate best to each of these examples. Okay, so there might be some where you think, okay, that probably fits into a few, but try and put each one into an example. And you'll probably notice here that the overall example is the same here. We're talking about using an app, so creating a health app that's going to go out to lots of people and provide health messages. So which components of this app development and use fit with each of these principles of the social model of health? And again, there are advantages and disadvantages of the social model of health. So if you'd like to, having done the biomedical advantages and disadvantages and looking at this now, you could pause this and have a think for yourself. What do you think are some pluses and maybe some minuses? So an advantage is that it promotes overall health and well-being. It's giving people knowledge and information to have that overall health and well-being that we talk about. It assists in preventing disease. So remember, biomedical approach is about treating or curing. This is about preventing, so stopping people getting sick in the first place. It's more cost effective than the biomedical approach. So if you think, for example, if you have a anti-smoking campaign and that prevents a lot of people from smoking, or it helps people to quit smoking and they don't get sick, that's much cheaper than the cost of those people having to have treatment and surgeries and medications. It really focuses or assists vulnerable groups. So we talk a lot about equity, so making sure people who need the most help get the most help. It provides education that can be passed down from parents to children and then onto their children. And that's really important because remember we talked about empowering? Healthcare shouldn't just be about people having to see professionals to help them. The idea is that if we give people knowledge and understanding, they can help themselves and make healthy choices for their children, and then their children are more likely to do that with their children. And it shares the responsibility of health and well-being. So remember that collaboration. It's looking at health as a really holistic thing and saying health is not just the responsibility of the health department and doctors and hospitals. It's the responsibility of everyone. And I think actually what's happening right now with coronavirus is a really good example of this, where if we didn't have a kind of social public model of health, maybe nothing would have been done. And everyone would have said, oh, it's up to the hospitals to be able to deal with what happens if everyone gets sick. Whereas instead our government has said, no, it's up to everyone to make sure that this doesn't happen. We can't afford for our healthcare system to be really, really, really challenged. So we're going to close cafes and things like that for a little while. We're going to ask people to stay home. We're going to tell people to work from home. So that's really made it the responsibility of everyone. Some disadvantages. Not all diseases or conditions can be prevented. So in the same way that not everything can be treated, not everything is due to lifestyle. So for example, certain types of breast cancer, that's not due to lifestyle choices that someone makes, that's often a genetic thing. So if we didn't have our biomedical approach to treat that, we'd basically be saying, well, you just have to put up with these things if it can't be prevented. It doesn't address individual health problems. So again, a good example is, if we've got, the whole population in general being healthy, that's great. We've got a really productive, healthy population. But let's say you're an individual and you get a health problem. This model doesn't help that. You still need that biomedical approach for your health problems. It doesn't technically promote advancements in our medical and technological discoveries. Okay, so we still need that biomedical approach to keep things moving forward and to keep inventing really important discoveries. And obviously the really big thing, when we're talking about empowering people and giving them knowledge, hopefully with the aim that they improve their health, they don't have to follow those messages. So people can choose to ignore health messages, and that's always going to be a risk. That some people might say, okay, I know the risks of doing all these things, but I'm going to do them anyway. And that is their choice, and we can't control that. So once you've got these jotted down, just jump into question 6 and answer that. I quite like this ancient proverb, you've probably heard it before, but it's a really good example of this social model of health. So this idea of if you give a man a fish, you feed him for a day, but you teach a man to fish, you feed him for a lifetime. So I think it's really saying that if you just give people, say, treatment and medicine, that might make them better. But if you don't also teach them how to improve their health, then over time, they're going to keep needing that support. They're not self-sufficient, they're not empowered. Okay, we're almost there, I promise. As I said early on in these slides, an effective health system has got both biomedical and social components. In the past, I think some students get really confused and think, we have old public health and then biomedical and then new public health. I think it's important to see that they're different but interrelated things. This graphic was actually from the textbook, so you can have another look in it there. You can take this from the slides if you'd like. But on the top half, we've got our kind of public health interventions, and on the bottom we have our biomedical model. So the biomedical model has always existed. I mean, even thousands of years ago, people were doing treatments. They might not have been what we would use now, but people have always aimed to figure out what diseases are and to treat them and make people better. So that biomedical model has always existed and it always will. Okay, so we're always going to have that. The old public health measures that we kind of talked about, They obviously came in early 1900s and lasted till around 1950, 1960. Some of these things obviously are still in place. So we didn't then just say, okay, well, let's get rid of our sewage systems. Let's go back to poor housing. It's just that they were already implemented. They're not considered health measures anymore. And then new public health, as we mentioned, started in the 1970s and continues on today. And that's our social model of health. So looking at improving things. So I think the important thing to think of, especially if we look at now where we are now, these things work together. Okay, so we have public health to send healthy messages to try and prevent people getting sick, but we still need biomedical approach as well to be able to treat diseases or injuries that do happen. All right, the last thing I want you to do is to go back into the Google Doc, and for each of these examples, just to show that you've kind of understood what we went through today, for each example, do you think that is a biomedical thing, a social thing, or maybe both? So when it's both, it might be something that obviously needed medical technology to be invented or created, but it is targeted at the community. So rather than at an individual. Okay, so that is question 7. And what we're going to look at in the next session. So we covered this today. We covered most of this. We looked at this. We looked at the relationship between the two models. We haven't done this. That will be a session on its own because there's quite a bit in that to do with what we've done today, but it's kind of specific things that we need to cover. Okay, so that will be our next session. All right, take care.